So only two electrolyte imbalances, just sodium and potassium. For sodium, we will only discuss signs and symptoms because the management for sodium imbalances vary depending on the underlying cause, meaning whatever led to it will determine the interventions. Okay. To help you remember the manifestations, because there can be overlapping between high and low, and this will apply also with every other electrolyte. Always look at what does this electrolyte do. So generally speaking, we have two sets of electrolytes. We have anions and cations. So negative and positively charged. Regardless if they have a positive or negative charged ion, they do the same thing, which is to excite cells. So if you have and certain, of course, all electrolytes are present inside and outside the cell. However, they tend to stay in one compartment more than another. For instance, sodium, this is most abundant in the blood or outside the cells. They excite cells, however, they have less control over other body systems than they do in the brain. So most of their effects are on neural function. Again, they have effects on all cells. However, majority is in the brain function. Here are your manifestations. So if you have less sodium, when we say hyponatremia, where is it actually lower at? Inside or outside the cell? Well, it's a major extracellular cation, right? So therefore it's lower outside. That means they are higher in ratio to inside the cell. Okay. So look at the manifestations. As a result of low sodium in the bloodstream, as a result, they have anorexia, nausea, vomiting, headache, lethargy, and so on. However, if you read the paragraph, they will vary. The severity of these manifestations vary depending on the severity of the deficit. And these are the common causes. Like I said, treatment will vary depending on the cause, what led to the sodium deficit. But generally speaking, when we manage, the way we manage low sodium is fluid restriction, based on the concept of where water goes or where sodium goes, water follows. So if we have less sodium in the in the bloodstream, what do you think we will do with fluid intake? Actually, we will have to restrict fluids. Okay, so the way we manage hyponatremia is restrict fluids, okay? Generally speaking, depending again on the level. I mean, the underlying cause. Okay, I'll come back to this table when we get to the, you know what, let's do it now. So for hypernatremia, this is now the opposite problem. These are your manifestations. So it's higher outside the cell, meaning it's higher in the bloodstream. So the patient will be thirsty because it's less inside. Okay, elevated temperature. You see the sets of signs and symptoms? If you compare them side by side, most of their effects are in neuro, correct? So here you have lethargy, dizziness, confusion here in hypo. Then similarly, you have the same. You have hallucinations, lethargy, restlessness, and irritability in hyper. Can cause seizures. However, hyponatremia can actually also cause seizures. So you see seizures in both. But seizures, the seizure threshold is lower in hyponatremia because think about it. If sodium is low, in the bloodstream, what is the fluid status of the brain cells according to osmosis? What happens to the fluid status of the brain cells according to osmosis? If the patient has low sodium, so water will go where? Into the brain cells, correct? So there will be cerebral edema. Can that trigger seizures? Yes. So one of your interventions in managing hyponatremia will be seizure precautions. Give me 5 seizure precautions actions. Oxygen, suction. Okay. So let's review. So pad side rails, and that means the bed is also lower, right? And then suction, oxygen setup. What else? Loosen, okay, loosen restrictive clothing. And number 5? And put it on the left side. That's actually when they're having a seizure. Okay. You're trying to prevent one. What's number 5? How do you stop a seizure? No, I mean, I didn't mean, not hold them. No, I didn't mean restrict their movement. How do you stop a seizure? Let's say the seizure is lasting more than 5 minutes now. The patient's gonna die. IV. Okay, IV lorazepam or IV diazepam. Okay, so what do you need? An IV access. Okay, so that's number 5. What are they again? So when the doctor, do you have to wait for the doctor to order seizure precautions when a patient's sodium levels are low? No. We are trained. We know this patient's high risk for seizure, so you institute it. Does it harm the patient if they have an IV access? No. Does it harm the patient if the rails are padded? No. Does it hurt if you have oxygen and suction setup? Okay. All right. Okay. So initiate it. That way, when doctor writes it, what do you say? Way ahead of you. You're too slow. Stop slacking. I know. I passed 241. All right. The decision whether or not to replace sodium lies on the doctor. Now, it's not all the time that if your patient's sodium levels are low that we replace it. Not necessarily. Okay? So it depends on the level and the underlying or what the doctor thinks is causing the low sodium. Okay, so we don't uh, do it every time. It doesn't mean sodium's low, we give them normal saline IV. Not really. Okay. Really depends on the level and the cause as well. As I mentioned, water restriction, okay, is most of the time it's more than enough, okay, to correct the sodium imbalance. Especially if the doctor orders 3% sodium chloride. Okay, so very high risk for fluid overload. There are 2 drugs that are usually given for hyponatremia, but they're seldom done because they raise the sodium levels too high, and you'll end up with hypernatremia. So there are 2 Vaptan drugs. So conivaptan or Coney, and I think it's it's still Vaptan, but I forgot the starts with a T. Oh, tolvaptan, sorry. So tolvaptan or conivaptan. Both are only used in the hospital setting. Because why again? What's the number 1 side effect? Hypernatremia. So we can't risk the patient treating these patients with these drugs at home. Okay, they have to be inpatient. Are we clear? So you'll never see this prescribed outpatient. All right. Okay, so we already know about seizure precautions. And remember, the patient's confused, there's confusion, lethargy, so fall precautions. That's about it. Let's go to too much sodium now. Let's go back to the table. Here are your manifestations. If you have hypernatremia, here are your manifestations. And for management, it's typically done with um, treating the underlying cause first and then IV fluids. But I repeat, for the exam, I will not be testing you on management of hypo and hypernatremia, only manifestations. Okay. Because yes, we mentioned a few interventions, but again, these interventions depend on the underlying cause. And since we did not discuss the underlying cause specifically yet, it might confuse you, okay? May cause confusion. All right, let's go to potassium problems now. So same pattern, we have low or high. Let's start with low. Unlike sodium, sodium is the major electrolyte outside the cell. This one is the major one inside. Okay, so the manifestations here are directly proportional. So if you notice, if you're see here, if you have low potassium, look at the manifestations. Low everything. Peristalsis is low. So therefore, does the patient have any appetite? Do they have any bowel movements? No, you got muscle, you got constipation, you have muscle weakness, heart weakness, and then respiratory depression as well. Because remember, the diaphragm is a muscle too. Okay, so all muscles are weak. So therefore, respiratory rate will be weak, effort will be weak. You have paresthesias, low BP because the heart weakens at the same time. There is ST depression. Okay. And then prolonged PR interval. Okay, so these are the manifestations. To be fair, for exam one, I will not test you on the ECG changes. I will test these on exam three and the final. Because we haven't done the ECG yet, which is module 8, that's for exam 3. Okay. So we'll skip these for now, but all the other manifestations are in play. Okay. And these are some of the common causes of potassium deficit. Now, unlike sodium problems wherein the treatment is depending on the underlying cause, in potassium deficits or potassium excess, the treatment is the same regardless of the cause. Are we clear? All right, so we will test sodium imbalance management, okay, for exam one. Okay, let's go to manifestations now. So remember earlier, I mentioned about potassium and kidney function? Yes, because it doesn't make a difference. Whatever is causing the potassium imbalance, the treatment is the same for all patients. Okay. So, you're low in potassium. So what do? We'll give you potassium. Okay. Potassium can only be given via two routes, orally or intravenously. There is no sub-Q, IM, or any other route for potassium. Either you eat it, drink it, or we give it intravenously. Okay. When we give intravenously, there's only one way to give it, infusion. We never push IV potassium. Are we clear? Okay. Why do we not push it? You will kill the patient. Okay. So the only time we push it is when we're executing somebody, capital punishment. Okay. So death, death by lethal injection. This is the lethal injection. Okay. Of course, we do it humanely. Okay. We sedate the patient, we paralyze the patient, and then we deliver potassium chloride to kill them. All right. And of course, the nurses do not participate in capital punishment. Okay. Only doctors are there. You'll never see. We have uh corrections, jobs. Okay. We have nurses, but we're not in the death row. Okay. We're not there because we're trying to treat. Okay. We do not kill people. Right? That's just against the code of ethics. Okay. For nurses, it's just you can't. Even if you're like some psycho and then you like to apply, I'd like to volunteer, please. No. Again, what do we check again before giving any potassium, whether it's oral or intravenous? Check what? Specifically what? Kidney, kidney function. Okay, always check kidney function. Of course, it's a given. You wouldn't have given potassium in the first place if it was already normal, right? So yeah, of course you check the level. But before giving it, let's say the potassium level is low and it's indicated. What else do you check? Kidney function. Either the urine output or BUN and creatinine. Are we clear? All right, very important, right? So always consider also foods because it's not all the time that we will be giving potassium supplements. Doctor may simply order nutritional treatment. Okay? Doctor may simply order the dietitian to give potassium-rich foods. Okay, sometimes that's enough because it's really serious when you have to give somebody potassium. No, that's because we can't really measure how much. So let's say the patient wants to eat bananas. It takes a lot of bananas to give, let's say, 20 milliequivalents or 40 milliequivalents. That's a lot of bananas. Okay, so you'll gag. So sometimes we can't meet it with nutrition, and then we have to give it either orally or intravenously. Obviously, when do we give it IV? Give me two conditions. Because you and me, are we on IV potassium? Why not? Because we're eating it. Okay. So what would be two conditions wherein you cannot give the patient potassium orally? Okay, either NPO or maybe some GI problem, right? They can't, no, they can't absorb it, so it's useless. So that's one. What's the other one? What is the severity of the potassium deficit? Mild or severe? Okay, moderate to severe, we have to give it intravenously. Okay. Now in practice, we because here let me show you under management. Under management, it tells you, again, I'll do the ECG things for exam 3. Okay. Here, under management. So oral is, of course, you can give as much as 40 to 60, okay, per day orally. There's really no concern there. The problem is with the IV. We are limited in the IV administration. So the limit here under IV potassium is the maximum you'll give according to the textbook is 20 milliequivalents max per hour. Okay, it's somewhere here. But in my years of nursing, I've never seen an order of 20 per hour. It's always 10. Okay. In fact, potassium doesn't come in any other concentration except 10. They do not come in 20 MEQ bags. They come in big bags of 40 MEQs per liter, but that's per liter. Okay, meaning you have to consume 1 liter to get 40. Okay, and we're not giving that bag over 1 hour. That's an infusion, okay, over 4 to 8 hours. So in practice, the maximum you can give intravenously, and again, it's not push, it's always a 1 hour infusion. It's only 10 to 20 milliequivalents. Textbook says you can give up to 20, but in practice, 10. Okay, I've never received an order to give more than 10 per hour. No matter how low the potassium is, it's only 10. Okay, so therefore, thinking about it, the most you can give for potassium intravenously is 10 milliequivalents per hour. So what do you think is the implication here? Knowing that if someone is at risk for potassium imbalances, especially potassium deficit, how should you approach it? Proactively or reactively? Try to prevent it in the first place because it's your problem anyway. You may say, oh, that's not me, it's the patient that's going to die. That's your patient though. It's 12 hours. You're gonna have to yeah, because of course, are you just gonna say, oh, it's not me? Yeah, I'm giving the doctor's order. Of course, you're affected here, right? But plus, in fact, if this patient does go into cardiac arrest, whose problem is it? Still your problem. Okay. So I hate it when potassium levels drop. Okay. So I always tell the doctor, this patient hasn't been eating. Okay. So I look at the INO, hasn't eaten for 2 days. What's the plan here? Okay, because I'm always concerned about potassium. Because what is our only source of potassium? Eating. We do not store it. Look at what's the range? 3 to 5. That's a very narrow range, right? So therefore, if you don't eat more than a few hours, is this a problem? Yes, it's a problem. All right. So patients who are NPO or not eating for more than 12 hours, for instance, should you be concerned? Yes. So always do proactive action. Okay, tell the doctor, hey, I haven't been feeding this patient. Or let's say the patient won't eat, then we have to do something. Okay, so what's the plan? Are we gonna let this patient die or are we doing something? So like I said, concentration 10 in 100 ml. That's the ratio. 1:10. Okay, so 10 milliequivalents to 100 ml. That's 1:10, right? Or if it's a 40, then that's a liter. Okay? I've never seen this 40 in 100. You won't see that. Okay, so you'll see 10 in 100. And there's only two places you can access potassium in the hospital, meaning potassium vials, okay? In the ER and in the pharmacy. That's the only two places. So you won't see that on the regular floor, not even in ICU. They won't give us access because why? It's dangerous, okay? You could make a mistake, okay? You can kill somebody, okay? During my time, I won't say which hospital, well, you know which country, but I won't say which hospital. Okay, so we had multi-dose vials because we didn't have premix bags. No, unlike here, you have potassium bags already premixed. Okay, they're in 1 liters or 100 ml bags. There, we had to mix it ourselves. So we had to get the potassium, add it to the solution, and then infuse it. They're right next to an NS vial. They have the same color label. They have a white label with green letters, green colored letters. So if you don't read properly, you could grab the potassium chloride by mistake and thinking it was sodium chloride. And the difference only K and Na. Okay, so if you're not paying attention, which one you grab? So I don't know if I've killed anybody. I'm sure no, because I gave it and then nobody nobody croaked. Okay. All right. So any questions about potassium? So what do we check again before giving it? Okay, kidney function and of course the potassium level. And then when it's IV, how much can you give? 10 per hour, right? 10 milliequivalents per hour. And can we push it? Okay, no. So again, so renal function, here's the warning. Okay, so that's not BS. Renal function should be monitored through BUN creatinine and urine output. Are we clear? Okay, so that's any potassium supplement. Doesn't say IV, doesn't say oral. Just say any patient receiving potassium supplement. Okay, let's go to hyperkalemia. This is now too much. Let's go to the manifestations. Okay, so here are your manifestations. So remember, this is intracellular, so this is too much, right? There's too much inside the cell. So now we have a pattern of overexcitation. Here you have underexcitation, correct? See here, you have low peristalsis, okay, resulting in nausea, vomiting, constipation. Then here, you got too much. Now you got diarrhea here, you got abdominal cramps, distension. You have tachycardia. Weakness, though, is common, both whether it's low or high. You see muscle weakness there. But there's a difference in the ECG. Okay. Again, we'll reserve the ECG later when we get to module 8. And here are your potential causes. So from kidney failure, again, any kidney injury or chronic kidney injury always causes hyperkalemia. Also, any acidotic condition that includes lactic acidosis, which is happening in sepsis. Okay, so you also see hyperkalemia there. Oh, here's the fact, by the way, why we check kidney function. This is the rationale. You guys never, you just took my word for it. Oh, okay. Okay. Or the textbook, although the textbook did say it, right? Renal function must be checked. Okay, here's the rationale. 80% of our body's potassium leaves the body through the kidneys. That's your rationale. Okay, so that's why is it important to check kidney function? Yeah. Yes, because without kidneys, potassium can't leave the body. Okay, so we do have other ways to eliminate it. Only 20% is through the skin and the GI tract. So keep that in mind. So when we get to the interventions later, one of the interventions to eliminate potassium, especially if the patient has AKI, is through the GI tract. So we're going to induce, well, not really diarrhea, but we're going to induce a bowel movement. Okay, because in an effort to eliminate potassium. Okay, so we already know the manifestations. Let's go to management. How do we get rid of potassium? There are many ways to do it, depending on the level. And if it's mild, we can do the other track, the oral tract. Okay, so there's three ways to do this. You can either eliminate potassium, you can antagonize its effect, or you can shift it. Okay, there's three ways to lower potassium. Unlike of course, if it's deficit, we have to raise it, right? That's the only goal. Give it through mouth or intravenously. In potassium excess, there's three ways to do it. Again, what are they? Eliminate, antagonize, or shift it. Okay, by shift, we meaning momentarily put it somewhere else. Because when we say hyperkalemia, where is it really high in? Inside or outside? In the bloodstream. Okay, so it's high in the bloodstream. So we need to put it somewhere else because it'll cause harm. All right, I already mentioned about the kidneys, right? Okay, so any kidney failure patient always assume hyperkalemia. Okay, whether it's acute or chronic kidney disease, the main problem and most life-threatening problem is hyperkalemia. Just depends on, well, how bad. All right. So first is, oh, this is hypo, sorry. You're in hyper already. Okay, I mentioned acidosis, right? So any acidosis will cause hyperkalemia. All right. So let's start with non-emergent. Okay, so non-acute situations, meaning mild hyperkalemia, say 5.2, 5.3, under 5.5. Okay, so sometimes it doesn't require interventions. You just you just treat the underlying cause, what's causing this. Okay, so maybe it's a medication, stop that, or maybe it's a diet. Okay. But if it's not, we can't identify the cause, we have to treat it. Here's the simplest. If the patient's alert oriented, we have good bowel function. Okay. The requirement is good normal bowel function, meaning they have peristalsis. There's no peristalsis, then the oral route is not indicated. So you heard of Kayexalate, right? Okay, so forget that name because you won't see that name in the NCLEX. NCLEX only uses generic. So the generic for Kayexalate is sodium polystyrene sulfonate, SPS. This can be given by mouth or by enema. Who will get it by enema? Well, obviously patients who have decreased mental acuity, decreased level of consciousness, lethargic, for instance, or can't swallow, can't eat, or refuses to swallow. This thing is nasty. Okay? It doesn't taste good, makes you gag. So some patient refuses. They'll try. No way. I'd rather die. I won't take it. So we'll give it to an enema. Okay, so we'll tell the patient, oh, you don't have to taste this. Okay, put it in a bag, and then okay. So whether you drink it or give it to an enema, it will promote a bowel movement. Okay, so what it does is it will absorb potassium and then eliminate it in the feces. Side effect, of course, is diarrhea, okay, or let's say hypokalemia. In severe, because the problem with this route is takes 2 hours to work. It's too long. So in severe, can we consider this route? Maybe, but not the first option. Okay, so we'll give this, but this won't be the first order you receive. The first order you'll receive is IV. Okay. By the way, there's a newer drug. This one, Patiromer, Sorbitex, is the new SPS. Okay. Although I've never seen this in practice, I've only seen this in textbooks. I haven't seen this in hospitals. At least the ones I go to. I mean, I go to Montefiore, no, Moses and the Weiler campus. They don't give it. St. Barnabas, no. Jacobi, no. I know the city hospitals don't. So I don't know where to find this thing. But it's in textbooks though, so it must be ordered somewhere. Okay. But again, I've never seen it. I've never actually given it. So that's the new SPS. Okay, so same action. It eliminates potassium through the GI tract, promotes a bowel movement. And just like SPS, what is the requirement before you give it? Normal peristalsis. There must be normal bowel function. Okay, so emergency meaning, is this severe? Yes, this is seriously high levels of potassium, meaning moderate to high. So there's same thing. So we eliminate it, we antagonize its effects, or we shift it. Okay. So first option is IV calcium gluconate. What is the effect of IV calcium gluconate? Within minutes, it will antagonize the action of potassium. So did it eliminate potassium? No. It simply antagonized its effect, meaning can it cause harm to the patient? No. Its effects on cardiac function will be antagonized by calcium. Okay, so that's one way. So you give calcium gluconate. Calcium chloride is also okay, but it's either or. Okay, the problem is one of them right here. So calcium gluconate has higher calcium compared to calcium chloride. So if you have a concern of the patient's calcium levels, then you'll choose which one? Calcium chloride, because it has less potassium. Okay, so that's the only difference between the two. But either or can be used, okay, depending on the patient's calcium levels. So that's one option, right? To antagonize it. Now, you won't see one order though. If it's severe, you'll see multiple orders. Sometimes you'll see all four. Okay, but mostly we get 3 out of the 4. So one order we'll see is calcium gluconate or calcium chloride. Okay, we'll give that IV. Next is, that's calcium gluconate. Next is sodium bicarbonate. So you may see both ordered at the same time. Doesn't matter which one you use first, which one you give first. So either you give calcium gluconate or chloride first, and then sodium bicarb, or vice versa. Doesn't matter. What is the action of sodium bicarb? Shift potassium into the cells. Okay, so that's the effect of IV sodium bicarbonate. Next, regular insulin and hypertonic solution or dextrose solution. Now, this option is not one or the other. They have to be given both. Okay, you can't give IV regular insulin or dextrose. They both have to be given. This is the rationale. What is the effect of regular insulin? What will it do to the blood glucose? What's the effect of insulin? Okay, it's going to drop blood glucose, right? Is the patient's glucose high here? Is that why we're giving this? No, maybe, but it's really the purpose is to lower potassium, right? Shift it. So, yes, you will shift potassium, but what will happen to the sugar? It will drop. So, therefore, that's why you give dextrose with it. Are we clear? Okay, so that's the reason why we give both. Okay, so you give regular insulin IV, can't give it sub-Q, won't work. It has to be IV. And it's not Lispro, okay? Not Lispro, not Lantus, only regular insulin. It is the only insulin used for hyperkalemia, okay? Plus, this is the only one you can give IV. The other insulins are only sub-Q, okay? So this is the only IV route or sub-Q route is the regular insulin. Are we clear? What's this gonna do? Shift potassium. So the same effect as bicarbonate. Okay, very good. And then we had calcium chloride and calcium gluconate. They do what? Antagonize, right? Okay, so antagonize, and then we got here that will shift it, sodium bicarbonate, and then dextrose with regular insulin IV. Okay. Another option is diuretics. Now, diuretics, though, the problem with this is, yes, it will lower potassium. We give furosemide, for instance, or thiazide, hydrochlorothiazide. What will also drop? Other electrolytes as well. So it is, yes, we always talk about potassium, right? When we say diuretics, but if you read the drug book, diuretics actually lower everything. We're just more concerned about potassium, but yes, it will lower calcium, sodium, magnesium as well. And not to mention, it will also cause fluid loss, correct? Okay. So it's not really a commonly received order. So the orders you'll expect is or calcium chloride or calcium gluconate, sodium bicarbonate, regular insulin with dextrose, or let's say diuretics. There's one more. You can give albuterol. Okay. So what does this do? Shift the potassium as well. So when given IV or nebulizer, okay, so you can give this. Be careful, okay, because the albuterol here has two preparations. The one we give nebulizer, of course, is an inhalation only. You can't give that IV, okay, because it's not parenteral grade. Are we clear? All right. So just be careful about the order. But doctors usually order the first three. Okay, so sodium bicarb, calcium gluconate, insulin with dextrose. Sometimes they'll order albuterol, but um, Not all hospitals carry the IV albuterol. Okay, so all they order is the nebulizer. So yeah, you can give it nebulizer through, but doesn't have the same effects as, as strong effects as the other three. So most of the time you'll see the calcium gluconate. Okay. So let's say all of them are ordered, SPS or patiromer, and then calcium gluconate or calcium chloride, and then regular insulin with dextrose, and what's the other one? Diuretics. Which one will you give first? Which one will you give last? It would be the SPS. Okay, because that will take the longest. Because if you think about it, the three interventions we chose, did any of them eliminate potassium? None of them did. Yeah, they either antagonized or shifted it. Which one is the only one, or which two were the only ones that will eliminate it? Actually remove it from the body. Or diuretics plus the SPS, right? Or patiromer. Those are the only ones that actually removed potassium. Okay. But again, why did I choose SPS last? Takes too damn long. Okay, takes 2 hours. So if my patient's potassium levels are critically high, I want to lower it fast. Okay, doesn't matter whether I shifted it, I antagonized it. I want it low. Okay, because I want my patient to be alive over the next 2 hours until the SPS kicks in 2 hours later, and then I'll let the next shift worry about it. Okay, I just want to get through this 12 hours. All right. And then last resort, if we can't lower potassium in on any of those interventions, then we'll have emergency dialysis. And prevention, of course, is good. So patients with who are at risk again for hyperkalemia, any kidney problems, right? Whether it's acute or chronic kidney problems, shock patients as well, right? Doesn't matter what type of shock, whether hypovolemic, cardiogenic, obstructive, or septic shock. When there's lactic acidosis, potassium always follows. One last reminder, because we're going to do heart failure next with diets, because the sodium restriction in heart failure is pretty brutal. Imagine 2 grams sodium. You know how much 2 grams is? It's like one serving of potato chips for the entire day. No, those potato chips you have, only one serving. A bag has multiple servings. So just one serving. However, you have to divide that to however many meals you have throughout the day. So how will your food taste? All right. So therefore, patients will have to resort to salt substitutes, which are made of potassium. Okay, so be careful about salt substitutes. Okay, um, especially the cheap ones. Cheap ones are made of potassium. There are non-potassium salt substitutes, which cost like 6 times more. Okay, because how much is Morton salt? Like $1, right? Maybe 1.99. So salt substitutes are about the same, $1, 50. But who spends $8 on a salt substitute? Okay, all right, but um, you know what I'm saying, right? So people will, yeah, so people will use salt substitutes, and not knowing that, oh, I didn't know this was made of potassium. Then they're taking certain drugs as well for heart failure, which can cause. Do you remember which one can cause hyperkalemia? Okay, we'll discuss that last week. That's it for today. I'll give you early dismissal.